Good afternoon. This is Kelly Piper with the California Healthcare Foundation, and thank you for giving up your lunch hour to be with us today. We are all providers and plans working on integrating care for patients who don't fit into neat buckets of just chronic pain or just addiction or just mental health problems or just medical problems. We're all here because we've figured out that for the patients who are most in need, the integrated care model works much better. Thanks to your input, we've brought today a pain and addiction expert, Dr. Howard Kornfeld, and Dr. Kornfeld really led the way in new thinking about the overlap between long-term opioid use, dependence, and addiction, and has advanced much of the literature on the use of buprenorphine in chronic pain. And buprenorphine is really, by an accident of history, pegged into an addiction treatment whole, but it's actually very effective in chronic pain and has very unique qualities to make us think differently about why not only is it an option for chronic pain, but is it really an evolving necessity. And the goal of our presentation today is to really debunk some of the myths and misunderstandings about buprenorphine in addiction and pain treatment, to talk through new ways of bringing people onto buprenorphine treatment that are much easier for clinicians to manage and less punishing for patients. Even though the presentation is fairly clinical, we do think it will be of broad interest to non-clinicians as well. So again, Dr. Kornfeld has two main roles. He is the founding medical director of a pain management and functional restoration clinic at Highland Hospital, where he sees patients with Medi-Cal and tremendous medical and social complexity. And he also has a treatment program in Marin County. And like I said, if you Google him, you will see he is widely published and has done a lot of interesting work with practical research. On the next slide. We do think it's important because he is a buprenorphine expert to make clear he does not have a conflict of interest. These are the things that we want to try and cover. The rationale for buprenorphine in chronic pain or mixed pain and addiction, understanding the waiver and regulatory environment, understanding the different formulations, because it's a little confusing about the different ways buprenorphine is available, how to rotate patients from full agonist opioids or other opioid treatments to buprenorphine, which is called induction, the core components about functional restoration, which is not just medication, but is many other components about getting people back to recovery and back to increased function in their life, and some of the common challenges that you may face as you try and bring this level of integration into your care models. And again, halfway through, we'll have some Q&A. So I'm going to turn it over to Dr. Kornfeld.
Well, the first slide is a little bit about the pharmacology of buprenorphine. Most of you probably have heard various aspects of this, but I'll summarize it. Well, buprenorphine was invented in order to find an analog of morphine that would be effective for pain but would have less of the negative effects of opiates and morphine in particular. The negative effects would be the addiction side, and the overdose side would be the most important two effects that were. There was a search for, the non-addicting, non-dangerous analgesic. So the graph there, the vertical axis says opioid effects, but I wanted to focus on the respiratory depression effects. And as you see, the full agonist opioid, for example, methadone, which is in parentheses, just as the dose goes up, it keeps going up. And at one point on this slide, it looks like it dropped out, but there was a line that was that said death. Because at a certain point with respiratory depression, death will ensue. And where a partial agonist like buprenorphine goes up, but then levels out. And that's very well established, that relationship with respiratory depression. Now with analgesia, there is a so-called ceiling effect that has been talked about with buprenorphine. But as it turns out, it's very difficult to determine a ceiling effect with analgesia for various reasons. Now, the other way that buprenorphine is talked about is as a partial agonist at the mu opioid receptor. So, 10 or 15 years after buprenorphine was invented, the opiate receptors were actually discovered, and they're often talked about as the mu receptor, the delta receptor, and the kappa receptor. And the mu receptor is the receptor that mediates most of the effects of opiates. And because it's a partial agonist, as it says on the graph, what that means is a partial stimulator of this mu receptor. And this partial agonism results in, again, safety with respect to respiratory depression, but it also limits the euphoria from the medication. So opiate addicts, or those who are experienced with opiates in general, find very little euphoria from buprenorphine, so that they often won't desire, double the dose for a psychic effect, because once they get a certain amount and they're not in withdrawal and they're not craving opiates, they don't want more of it. And so that's one of the main benefits. There's a little technical side which I'll be very brief on, which is the kappa receptor. Buprenorphine is a antagonist, where the other partial opiates that were invented in the past were all stimulating the kappa receptor, which causes a psychotic reaction if it's stimulated in a strong way. So buprenorphine is the only opiate that is partial at the mu, but antagonizes at the kappa, so you could raise the dose up and get more effect at the mu receptor without causing the psychotic reactions of the kappa. And so that is one of the reasons that on the slide it says less impact on mental health, because stimulating the kappa receptor may mediate some of the harmful effects of opiates in terms of mood dysregulation. And as you see, there's also less impact on the endocrine system, better pain management, fewer peaks and valleys. Now, what's amazing about buprenorphine, even though buprenorphine is a so-called partial agonist and, again, thought to be weaker, many times when we convert patients from OxyContin or methadone or morphine to buprenorphine, they actually have improved pain management immediately, or if they don't have it immediately, they will eventually have it over a period of days to weeks, and we'll talk more about that. I'm going to go to the next slide. What happened is since early in the 20th century, it's been illegal for doctors to prescribe opiate drugs to addicts, even if the doctors were trying to help them by weaning them off the drug. And as you all know, there's an exception emerged in the mid to late 60s with methadone, and methadone maintenance was started, and that was sort of the first kind of waiver of that prohibition. But then with buprenorphine, the whole idea of it was, let's get an opiate drug, an opiate-like drug that's effective for addiction into the hands of primary care doctors and any specialist that treats these kind of patients. And so with that, the laws were changed, and a new law called the Data 2000 was passed by Congress and really ratified in all the different states also. and that allowed an FDA-approved drug for addiction, such as buprenorphine, to waive the provisions of another law called the Narcotic Addict Treatment Act and allow primary care doctors or other doctors not in a methadone clinic to treat addicts. Now, if a doctor is treating only pain or essentially only pain, one does not need this waiver. The waiver is also sometimes called the X number, because when you get the waiver from the Department of Health and Human Services, that allows the DEA to give you essentially a new DEA number. But instead of giving you a new DEA number, they just take the first letter off your old DEA number and put an X on it, and that's called the X number. A lot of the pharmacists will refer to that as the this waiver as the X number. Now, of course, you know, many pain patients have had a history of addiction, or maybe you're treating a chronic pain patient, but you feel they have a cannabis addiction, or they're dependent in a dysfunctional way on some other drug, such as a benzodiazepine. But I would say if it's primarily a pain patient, doctors can feel confident that they actually don't need this waiver to do so. Now, if your patient population is such that you're expecting to have addicts who are using street opioids, then even though they have chronic pain, I think it's a good idea to then to use the X number or to get a waiver. Now, to get a waiver, it's quite easy. There's an 8-hour course, either in person or sometimes a 4-hour course online, 4-hour course in person. These courses are offered by the American Society of Addiction Medicine, the American Academy of Addiction Psychiatry. There may be other providers of this, and it's a relatively easy thing to do, and then you apply for this waiver, and you're initially allowed 30 patients. So if you see at the bottom, you're initially allowed to treat 30 patients with buprenorphine for addiction, and then after a year you can apply to treat 100 patients. Now, there's legislation being promoted that would take these limits away. The pros and cons of having a waiver, really, it's mainly pros. The one challenge of having a waiver is that built into this law is a requirement that the DEA audit practices that have waivers every 5 years or so. So I've been doing this, you know, for 10 years, and I've only had one audit, and it's not a unfriendly audit. It's not like, you know, they break down your door and ransack your office. But on the other hand, they do come unannounced, and they are the DEA, and they want to see some of your charts and things like that. Also, if you're in private practice and you store controlled substances, they might want to see that you're keeping track of the controlled substances. So most clinics, doctors wouldn't have to worry about that because there's sort of a pharmacy managing that. But if you're in solo private practice and you have that, you have to be prepared to show them that you're keeping all the paperwork in order. I'm hoping personally that they do away with this kind of a DEA audit, because I think that it does intimidate some physicians, and ultimately there's not going to be a need for this. You don't get audited for prescribing much more dangerous drugs like OxyContin, etc. There's a standard protocol for shifting a patient from a full agonist opioid to buprenorphine. This could be heroin use. This could be prescription opioid use that is obtained on the streets. This could be prescription opiates that are prescribed. But however the situation might be, there's a standard protocol for starting buprenorphine. The reason there is this protocol is that the one strength of buprenorphine, one of the big strengths, is that it binds very tightly to the mu receptor, and it will actually, and that makes it a safe drug in many ways. It gives it a longer acting profile. It actually safeguards addicts, because once they're on the buprenorphine, if they use heroin or other opiates on top, they tend not to get, they tend not to die, as they often do, because when addicts get clean, when opiate addicts get clean, but then when they use again, that's a time when many of them overdose and die. But if they've got buprenorphine on board, the presence of buprenorphine on the receptor tends to blunt the respiratory depressant effect of the added opiate, and many lives have been saved this way. The corollary of this, though, is that if a patient is on the full agonist opiate, whether it be heroin, whether it be methadone, whether it be OxyContin or morphine or Dilaudid, if they're dependent on that, and you give them sublingual buprenorphine, which is the only way buprenorphine was available initially and the only approved way for addiction, if you give that to them in a significant percentage of the patients, at least 50% or more, it will kick off the other receptor in a way and create a precipitated withdrawal situation, and the patient could get quite uncomfortable, theoretically could even become psychotic or violent, and you really want to avoid that. So what you do is you have them stop their opiate prior to the induction process, and have them develop early to mild to moderate withdrawal, opiate withdrawal. If they're using heroin, they need to wait at least 12 hours, usually more like 24 hours, and most heroin addicts will have adequate signs of withdrawal. Then for immediate release oral opiates like hydrocodone or oxycodone, it usually takes at least 24 hours. Depending on the dose, it could be 24 to 48 hours. Methadone is the big problem. High-dose methadone takes often days to wear off, where a real precipitated withdrawal, or a real withdrawal is noted. And so with methadone, instructions are to have the patient taper to 30 milligrams of methadone, and then to wait 24, sometimes 48 hours before initiating buprenorphine. So these things are laid out by the PCSS-MAT, and this was the original NIDA. NIDA puts out something called the TIPS, TIPs, and this is TIP 40. These are all free, and the PCSS is online. And then another resource, bupractice.com, is also online, and it's funded by the by NIDA and by Samsung. So we have then a different situation then, often with a patient in chronic pain on opiate drugs. So I just divided the discussion towards a higher dose patient and then towards a lower dose patient. Now, a higher dose patient is often in recent years described as something greater than 120 milligrams of morphine, or greater than 100, and even the CDC is now suggesting that over 50 milligrams of morphine milligram equivalent is a potentially high dose in terms of the risks and benefits of opiates. Now this abbreviation MME seems to be the latest acronym that the CDC is using. later in this slide presentation, we'll see MED, morphine equivalent dose given, and there's different phrases about this. So the CDC just a few months ago said, look, carefully assess everyone over 50 MMEs and really look even more carefully at over 90 MMEs. So back to the reason, of course, with this higher dose patient is that the adverse effects of full agonist opiates are more prominent. The higher the dose goes in terms of risk of overdose, addiction risks, these other risks we talked about, the endocrine risks, etc. Now the low dose patient technically are not covered by the CDC guidelines, but this would be someone on, let's say, hydrocodone, 5 or 10 milligram, several times a day, might be under that 50 milligram MME. But why would you want to consider rotating this kind of patient to buprenorphine? Well, maybe initially you don't. You want to just get them off this drug using non-opioid supportive treatment, using functional restoration kind of treatment. And that would be ideally the ideal way to go. But sometimes these patients are dependent on this dose, even though it's low. They're unwilling or unable to taper it. Usually if someone has been on chronic, short-acting opiates, even in a low dose, my experience is that these patients are generally not doing well, that they have quite a bit of pain, that often they have depression, they're on antidepressants, they're on mood stabilizers, they're on antipsychotic drugs. They have a multiple medical problem. They're on many. They're hypertensive. Their weight is a problem. Again, as an addiction specialist and running a chronic pain clinic at a county hospital, I'm seeing the worst cases, and I'm sure there are certain people that do better on these low doses of opiates chronically. But I get concerned, even if someone has done well for 5 years, that doesn't mean they're going to do well if they're kept on another 10 years. At some point, the resiliency of their system is exceeded, and they may start developing, serious side effects of being on the opiates. This was more of the rationale for opiate rotation, medical complications from long-term opiate therapy. Full agonist opiates are quite potent in suppressing testosterone in particular in both men and women. Men obviously have some greater effects from this. Both sexes can suffer from different forms of sleep apnea, and although buprenorphine has not been studied sufficiently, there's a general consensus that the sleep apnea is less pronounced on buprenorphine than on the full agonist opiates. Same thing with the hypogonadism. We still see some hypogonadism with buprenorphine, but there have been studies and published articles showing less hypogonadism with buprenorphine. Opiates are often associated with excessive weight, or in some cases inadequate weight. The opiates seem to be associated with people being deconditioned, people being sedentary, disturbed circadian rhythm. So many opiate patients, if left to their own devices, end up staying up all night and sleeping during the day. There's something about the natural circadian rhythm that is disturbed. Constipation, of course, is universal with chronic opiates. Does seem to be worse with full agonists versus buprenorphine. Buprenorphine can still be a challenge with constipation. Some of the gastroenterologists actually call this condition an opioid bowel disease because the patients are so impacted. I've actually had a number of patients with small intestine bacterial overgrowth, which is a relatively newer diagnosis in gastroenterology that requires breath testing for the presence of methane and hydrogen. And then this whole hyperalgesia problem, you know, why do patients on opiates seem to keep needing more over time? Is it tolerance? Could be, but there's also a belief that there's an actual hyperalgesic state that sets in. This seems to be very much addressed with rotations to buprenorphine. Buprenorphine seems to often reverse this picture. It might be reversing the tolerance picture. Once a patient is stable on a dose of buprenorphine, they often don't develop additional tolerance significantly, and often they get the reverse tolerance. Over time, they need less buprenorphine, which really almost never happens with the full agonist opiates. Both full agonists and buprenorphine theoretically suppress immune function. Buprenorphine is documented to suppress it less. These are usually tests of immune cells and indices like that. But it's somewhat theoretic in that, you know, infections fortunately are not, you know, the main issue that opiate-dependent patients get. But there is a dysregulation of the hypothalamic pituitary adrenal axis with opiates. I think it ties in with the circadian rhythm disturbance also.
So Dr. Cornfield, let's pause for a second. Are there any questions so far? We haven't gotten anything in the chat, but certainly raise your hand or if you have any other questions. And then since we're about halfway through, you may want to just go a little faster through the slides just so we can make sure to get to all the content. Okay. And we may want to skip the slides on the buccal formulations because people do have access to slides and can read them later.
Yeah, the only thing I want to address in this slide is that currently in Northern California, sublingual buprenorphine tablets appear to be prescribable under Medi-Cal with no TAR required, you know? And that may be different, Kelly, in Southern California, but...
yeah, across the state and Medi-Cal, there's no authorization requirements. If a patient has Medi-Cal and the prescription is done by an ex-licensed provider and it says on the prescription opioid dependence or opioid use disorder, opioid dependence is a little more tolerable for patients. It will go through with no authorization required. It can be more challenging with commercial insurance.
Yeah, and I could just tell you, in Northern California, with for pain, if you just put buprenorphine 2 milligram, and you don't even have to write for pain, that goes through now without a TAR also. So we'll go to the next slide. These are the three forms of buprenorphine currently available. The first two are for pain, the patch and the buccal mucoadhesive. We won't. There's a range of morphine equivalents. Basically, the patch and the buccal mucoadhesive, which is a very new drug, very low dose tablets, and sublingual film, higher dose. So, how do you get someone onto the sublingual buprenorphine? Well, what we have found that if they have a pain condition and the transdermal form can be used, technically the Butrans or the transdermal patch is not supposed to be used for addiction only because the waiver is only for FDA-approved medicines for addiction. The patch is approved for pain. So, but we have found that if you stick a patch on for a day or two or a little longer, then you can convert patients from full agonist opiates to sublingual buprenorphine without having them go through withdrawal first. If they're on methadone, this would be usually for a pain patient on methadone, but it theoretically could be a mixed patient. We find that the higher dose, we first convert them to a long-acting opiate like sustained-release morphine or sustained-release oxycodone, and then leave them on that for 2 to 7 days. Then we switch to a short-acting opiate like morphine, oxycodone, or hydromorphone, and wait for a day or two. This is actually the sort of the most humane way to do it. Sometimes you don't have the opportunity to wait. Sometimes you have to do it faster. But this is the ideal way, particularly if they have a serious pain condition. You don't want to flare up their pain condition. But once you start the patch, you put the patch on. The patches go up to 20 microgram per hour. We can get Medi-Cal to pay for these with a TAR, and we would recommend either 10 or 20 microgram per hour. Get that patch on. The patches last for a week, but you can start the sublingual buprenorphine even after 1 day or 2 days or 3 days of being on the patch. We found that the patch creates very mild withdrawal symptoms rather than the precipitated ones. And whereas in the standard protocols, you use something called the COWS, Clinical Opioid Withdrawal Scale, which is just a quick way to assess opiate withdrawal. You don't really need that in using this Butrans bridge or this transdermal bridge, because they're not going to get serious withdrawal. There's a home induction process with sublingual buprenorphine. The buprenorphine transdermal can be used. There's good reports in the literature. The PCSS in particular describes this. The TIP 40 from 2005 recommends against it, but things changed, and the PCSS is more current. The transdermal bridge facilitates. Of course, the patient needs support in the home, ideally, and they should come back to the office in a short period of time. Sublingual tablets are quite large in size and potent for buprenorphine. If you're trying to convert a lower dose hydrocodone or oxycodone patient, often even the 2 milligram size will give too much of a mu effect, and a patient will get nauseated or sweat, and as noted here, nausea, sweating, or dysphoria. So these tablets can be broken in half. These are generic tablets, but they often crumble. Rarely we have but we've done this enough to know that it works. We have the patient swallow the pill, and that reduces the bioavailability. Buprenorphine can be compounded by compounding pharmacists in very low doses. And finally, this mucoadhesive form starts at a very low dose, and is going to be a good option once we all become more familiar with how to use it. And this is a little slide about how to use it according to the prescribing information. An opiate would need to be titrated down to 30 morphine milligram equivalents, MME. That's roughly equivalent to these dosages. And although the prescribing information is not clear about how much time should go by, there is the so-called potential to precipitate withdrawal, and so that needs to be kept in mind. So a little bit of a period of abstinence with some mild withdrawal would probably be useful here. This is again about the buccal mucoadhesive. We won't dive into this. This will all be available. This will be marketed to clinics fairly heavily fairly soon. And we'll skip through this slide. how to convince patients to switch. Patients are often a little scared. You tell them you're going to take them off of their hydrocodone, their OxyContin, etc. They have a lot of trepidation. So we talk to them about how their symptoms will be better managed, that time is on their side with buprenorphine, that the longer they're on it, the better they'll feel. We often explain that their depression and their anxiety will get better. We sometimes share, look, the regulatory environment is not conducive, to staying on full agonist opiates. It's Schedule 3, meaning these can be called in. The functional restoration program that we want to initiate, psychoeducational groups, mindfulness, dietary, suggestions, like having breakfast. Most of our patients don't have breakfast when we first meet them. Exercise, different physical therapies, all of this is part of functional restoration. It actually works much better on buprenorphine, and I just said, the faster they're off the opiates, the earlier they're on buprenorphine, they will really benefit and perhaps even become healthy, wealthy, and wise. Inpatient stays. A lot of times we're called to an inpatient. Someone's been in the hospital for a long time. They've had some severe surgical problems, and they're on a lot of opiates. They're on large doses of IV or oral Dilaudid. All of a sudden, the surgeons say, you're ready for discharge, but the patient can't be discharged. They're on so many opiates that, and this would be a great opportunity to switch them while they're an inpatient to buprenorphine. The hospital stay can be shorter, etc. There's a lot of confusion about perioperative work with these patients. Some of the surgeons are concerned that if they're on buprenorphine and they operate and then they have postoperative pain, that the regular opiates won't work for breakthrough pain. There was an Australian study that's the only head-to-head study of patients on methadone and patients on buprenorphine who had elective major surgery. It turns out the patients on buprenorphine needed significantly less opioids for breakthrough pain in the first 24 hours. So anyone on opiates is going to be challenging postoperatively. They're going to require special care, whether they're on buprenorphine, methadone, OxyContin, etc. Kornfeld and Manfredi, myself and a colleague, we published 7 surgeries and 5 cases showing that people did well without going off the buprenorphine. If they go off the buprenorphine, then you have the headache of putting them back on the buprenorphine with all the induction problems, etc. And for some people, you're going to risk relapse. Common challenges and opportunities. Sometimes the pain will persist and even escalate on buprenorphine. We can add full agonists to the buprenorphine. We then have the challenge of tapering them back to buprenorphine. Many patients will have a euphoric recall of the full agonist opiates. Like they say, I have better pain relief, but I really miss the other opiates, or this just doesn't work because in the past maybe they got 2 hours of pain relief from their 10 or 20 milligrams of hydrocodone or oxycodone, but then they had hell at different parts of the day. Here they have a steady state, but they miss the euphoric periods. We find that we're able to get people off of benzodiazepines and zolpidem-like drugs. We find that the ADHD symptoms can improve, and we usually try to take people off of stimulants. Sometimes the stimulant was there because of the full agonist opiate. Same thing with the SSRIs and SNRIs. Often they've been on these for years. They're still depressed. And with the buprenorphine has some antidepressant effects that the full agonists don't have. I think a previous slide said that there's been some recent study with PTSD that it seems to have some effect. And there's some QTC considerations. The big picture is there's less QTC, that's prolonged QT interval, that can create a arrhythmia. A lot of problems with methadone, very few problems with buprenorphine. There are some warnings about this, but the consensus is that it's much lower risk with buprenorphine. And now we're ready for questions and answers.
So we had one question about a little bit more elaboration of the ability to taper off antidepressants and neuroleptics. I wonder if you could comment on that. You already mentioned the ability to taper off antidepressants, but how do you approach that? And with neuroleptics, how do you approach that?
Well, you know, as the clinicians know, a lot of people who are on neuroleptics are not schizophrenic, you know, or seriously schizoaffective or psychotic. You know, these have been added to antidepressants, sometimes per the label, or they've been given for anxiety, things like quetiapine and risperidone. And what we find is that when a patient is on the buprenorphine is like a platform or an umbrella that protects the patient from anxiety and depression. And we don't do anything drastic, but if they're on, if they're on, 200 milligrams of sertraline, and they've stabilized in the buprenorphine, we say, hey, why don't we go to 150 for this month? And they say, fine. They usually say, this never helped me anyway, you know? So we just lower it down, and we often don't see recurrence of anxiety and depression as long as we taper it reasonably slow. And the same thing with the neuroleptics. And I'm not talking about, of course, a schizophrenic or severely psychotic person, but these pain patients often, because they have such poor symptom control, that just more and more classes of drugs get piled onto them, and their basic problem is that they're opiate dependent and they have poor, they're on drugs that don't work for chronic pain.
Could you comment on treating patients with chronic pain and cirrhosis or other liver disease?
Sure. Buprenorphine is the safest opiate for patients with liver disease or kidney disease, and the reason is that most of the buprenorphine is actually excreted in the bile without being chemically modified or conjugated, and it's pooped out basically. So buprenorphine just kind of leaves the body. Now, with liver disease, of course, some of the cytochrome P450 enzymes are affected, and there can be a slightly reduced metabolism of buprenorphine, but because so much of it is eliminated just in the bile without being conjugated or oxidated, by the CYP system, it's safer than the other opiates, which need more of the liver machinery to metabolize. Same thing with the kidneys. With renal failure or on dialysis, there's not really a dosage change of buprenorphine because it's eliminated otherwise.
So can you comment if a patient is on benzodiazepines and opioids, if what your approach is? Would you taper the benzodiazepine first, or would you switch onto buprenorphine while they're on the benzodiazepine and then consider a taper?
Sure. Well, I should say this. There's some warnings about buprenorphine induction and about using benzodiazepines. Sometimes benzodiazepines can help in induction. It's frowned upon by some experts because there's some overdoses in France where people were injecting buprenorphine and benzos. But that being said, the other problem, which is even more common, is, like you said, people on benzos and opiate dependents who were using buprenorphine. We tend to try to do the opiate first, and once they're stable on the opiate, we will then address the benzodiazepine. The exception being if they're on a very short-acting benzodiazepine like alprazolam or lorazepam, we might switch that to a longer-acting one that's a little more stable, such as diazepam or chlordiazepoxide or clonazepam. And then once they're stable on the opiate, on the buprenorphine, we find that that can be a platform or an umbrella, so to speak, to taper off of the benzodiazepines using, any one of a number of different methods to do that.
Great. Can you comment on the issue of buprenorphine with cannabis? This has actually been quite controversial. There were some programs in Northern California that were saying, we won't treat you if you're on cannabis. And I understand there's many California Society of Addiction Medicine specialists who've looked at the literature and that there's no change in the effectiveness of recovery, whether someone's on cannabis or not cannabis. And so I'm wondering if you can reflect on what is the evidence for a program to make that decision about whether cannabis becomes a rationale for discontinuing someone's buprenorphine versus whether you would consider them separate problems and treat the opioid use disorder or pain with buprenorphine and treat the cannabis as a separate issue. Could you comment?
Sure. Well, there's a couple of studies that one was, I think, 2013, and the other was a little older, 2003, that actually looked at whether it made a difference in the outcome of medication-assisted treatment with, I think the earlier study was only methadone and the later study was methadone and buprenorphine. And what was found is that it didn't really matter if they were using cannabis or not. The outcomes were similarly positive with medication-assisted treatment with methadone or buprenorphine. So there's that evidence. Then, of course, on the other side, there is the regulatory fears that different clinics have, and there are different pain clinics that are very vigilant, about the fact that they are prescribing federally controlled substances. They feel that if they get positive urines for cannabis, that they are overstepping their bounds in prescribing opiates. Now, I've never seen any pain clinic prosecuted for continuing to prescribe an opiate appropriately when there is a positive cannabis urine drug screen. I don't think there's anything in the law specifically about that, but there's obviously a great deal of concern about that. I think the VA system is grappling with it right now because there are states that are medical cannabis states, such as California, and yet VA hospitals have been very strict, being federal institutions, but it's all changing now because there's congressional efforts being made to not not penalize patients who are not breaking the law in their state, and the fact that cannabis does create dependency issues, does create issues of mood regulation. Certainly, it's not a very useful situation when patients come in to the clinic stoned and you're trying to deal with them. On the other hand, the life and death issue with most of these patients are the opiates, not the cannabis, and sometimes the cannabis is something that the patients have been doing for many years before they were abusing the opiates. And for them, if they can recover from the opiate addiction, you're saving their life whether they continue to use the cannabis or not.
And one of the most compelling arguments I heard is someone has high blood pressure and diabetes. We don't say we'll only treat your diabetes if your blood pressure resolves, but many times these are separate and coexisting addictions. And sometimes the cannabis is not addiction, sometimes it is, but treating them separately has some rationality. And we'll certainly send everybody on the webinar the references that were about the cannabis and the buprenorphine programs. There was a clarification question about is there an issue with the naloxone within the buprenorphine product? My understanding is that naloxone is not absorbed unless it's injected, and that if buprenorphine and naloxone is crushed and injected, that there might be a liver issue, but that if it's taken orally or sublingually, the naloxone is not an issue with the chronic liver disease. But could you comment on that?
Yeah, good question. I mean, I would probably give a liver failure patient the pure buprenorphine, even if they were an addict. Again, the presence of naloxone is a public safety measure, like a public health measure. It makes sense. On the other hand, as all of us know, if someone wants to inject something that really works, why would they even bother crushing Suboxone if they could get heroin as easily as they can in this society? So again, it's better to use the naloxone product with an addict, but if there's some reason like pregnancy or medical illness, it's a reasonable alternative to use pure buprenorphine tablets, and then you don't have to worry about what the naloxone might or might not be doing with liver disease.
Okay, Irene, we'll have one last question, and then we'll close the webinar. Dr. Kornfeld, we're so grateful for you spending the time. It was very helpful. As we mentioned, these slides and the recording will be available, and we'll send you those links. And the last question is there any pharmacodynamic interaction between buprenorphine and THC that would impact pain relief?
The impact what?
Pain relief.
Oh, pain relief. Yeah. Well, THC or, the related cannabinoids, CBD, cannabidiol, the cannabis plant has been used for analgesia for hundreds or thousands of years, and there's a potential for it to be additive or synergistic with opiates in some patients. I've seen that. I've seen other patients who use cannabis on top of opiates, and they get no further pain relief. So it's quite it's quite individual, an individual type of thing. But there's no reason to believe that it's antagonistic. The THC and at the cannabinoid receptor and the opiate at the opioid receptor would be acting both independently and not blocking each other.
Thank you again for everyone who gave up your lunch hour to attend. I always learn when I listen to Dr. Kornfeld. He's also got an amazing perspective on the history of buprenorphine and the history of opioids that if any of you are particularly interested, we can share some of his information on that. Again, we'll send you the slides and the recording. And Dr. Kornfeld, thank you so much for your time.
Thank you.